So I'm going to give a little bit of background as to why this is important and then how one tackles it. Now, firstly, immunisation is very, very, very well researched. It is the most cost-effective medical intervention we have, and for a lot of immunisations, it's actually cost-saving. And there aren't too many things you can say that for. However, having said that, if you wanted to do even more good, go and produce clean water, which is even cheaper. The Americans, as you can imagine, were first into the market, so to speak, with looking at the cost-effectiveness of this. And this figure comes from, well, it was published in 2004, based on data before that, showing that for every dollar you spend on MMR, you save $14. Now, there are very, very few things that you can look around and say you can do that with. Unfortunately, with most of the immunisations that now come along, because they are so expensive and because we are treating diseases that are less and less common, most of them are not cost-saving, but they are still cost-effective in nice terminology. As I said, I could go around the room and we could go through the schedule, but it would take too long, so I'm going to whip through it quickly just to remind you. Now, there are some immunisations that are not given universally. However, the population we are talking about disproportionately would need most of these things, and you will probably know that in the area in which we're sitting currently and a number of adjacent areas, BCG is in fact given universally to infants because of the high rate of TB we have. Hepatitis B in this country were not quite unique, but we fall into a very small group of countries who don't routinely give hepatitis B to infants. If I have to give this lecture in 2 or 3 years' time, I might change that. But that's the current status, and there is a good logic for that. And then there are the things that we give I must be politically correct. We offer routinely to all mothers on behalf of their babies or carers on behalf of their babies. And some of these are, back in the mists of time. So diphtheria came in, in the late 30s, early 40s. Tetanus not till the 60s, but whooping cough vaccine in the 50s. So some of these are very well established. Others are much more recent, like pneumococcal conjugate vaccine. But we now have a very high uptake of these vaccines. Then past infancy, any child who's had hepatitis B and is still at risk should be having a further 2 doses. We have the boosters between 12 and 13 months, and something that will be pertinent to our discussion later. It's usually not parents that object to having 3 injections at once, but health professionals who object or say that parents will object. It depends very much how you put it. If you say, Department of Health says I've got to give you these 3 things at once, you will get one response. If you say, aren't we lucky we can give 3 injections against very serious diseases all in one visit, then you'll get another response. And then, of course, before going to school, a second dose of MMR and boosters. What is now called the teenage booster of tetanus, diphtheria, and polio, and then most recent development in terms of giving to everybody, HPV to girls, and only girls currently in this country, at 12 to 13. So quite a complex program. So sitting in front of a parent of a 10-year-old and saying, is your child's immunisations up to date? Answer yes, doesn't necessarily convey the information you need to know whether they are truly fully immunised. In spite of having reasonably high uptake of these vaccines and them being very effective, there are some diseases that we do still have a problem with. And as you can see, this is how many years ago now? 4 years ago. An 8-monther who was admitted to Great Ormond Street and required ventilating for 3 or 4 days because she had measles pneumonia, an eminently preventable condition, and her mother was peeved, to put it mildly, because she assumed quite rightly that her daughter must have caught it from somebody who had measles, and the likelihood was that they weren't immunised. So that parent had made a decision not just for their child, but for this child who's under 1, and we wouldn't be immunising. We were doing quite well back in the 90s with our uptake of MMR and very few reported diseases, a little bit of a blip here, and then an enormous upswing here due to what you could call the Wakefield Blair catastrophe. And I'll explain after why Blair, if anybody wants to know. And 2 deaths here of immunocompromised children. So these, again, were not parents who'd made a positive decision not to have their child immunised. Child couldn't be immunised. A downswing there, but up again, and this is not the total year. So we still have a lot of measles in this country. It's an important disease. We don't have polio, but polio is still around in the world. And there are 4 countries, or at least last year there were 4 countries where it was endemic: Afghanistan, Pakistan, India, and Nigeria. And those are all countries which we have a lot of to and fro traffic with. The situation is better this year. So we're down to 1, 2, 3 countries where it's endemic. We have had now, I think, 1.5 years of India being polio-free, so not far off official declaration of eradicated, and a few cases in Chad. But there are still problems in Nigeria, and some of the areas of Afghanistan are still a problem. So although we don't have the disease in this country, we have a lot of to and fro traffic, so the potential for it to come back if we slip and don't ensure everybody is immunised. This is where we are with rubella, and of course what's important is congenital rubella syndrome. And here in the blocks we have the number of babies born with congenital rubella. So very successful, way down. These are the number of terminations in relation to pregnancy in rubella, and that's on this graph. So much higher numbers, and always worth remembering, because this is as distressing for mothers, obviously. Amongst these, disproportionately, are migrants who have either come from countries where they have no rubella program, or even worse, a half-hearted rubella program, because half-hearted rubella program will mean more women are likely to get it, and that's exactly the age group you don't want to get it. If we look at who gets it, as I say, it's disproportionately migrants, and then you can transfer that into actual figures, and don't worry about the details, but here we have HIV, hepatitis B, and syphilis, and these are all results from antenatal screening. And part of the world where I work, which is north central London, we have very high areas of those. So again, migrants disproportionately affected. You will have heard, unless you've been living on Mars, that we do have a problem now with pertussis. This is overall figures in the population, so a big rise this year. The rise last year wasn't unexpected because we do have intermittent epidemics of pertussis, but this was totally unexpected. And importantly, this is what's happening in the under 3s. And in the UK, thus far, we've had, at least last time I looked, 11 deaths from pertussis, all in babies, all unimmunised. Not so easily preventable. We still see the occasional death from diphtheria. And this is a child who moved in from abroad, I think came from Austria. And this wasn't, people weren't checking on the child's status when she registered. Parents registered, child's not immunised, I do not want my child to be immunised. Religious beliefs. But unfortunately, in May 2008, she developed diphtheria and in spite of care died from diphtheria in this country. No carriers were found in terms of isolating any organism, but one family member had travelled to Africa earlier in the year, and it is thought they may have been the source. So again, even though you sit in this country, you will interact with other people who move around, and that disproportionately applies to our migrant population. Locally, there was a case of diphtheria in a teenager who was admitted actually to the Whittington Hospital, managed to get a full house almost of diagnoses, because there was a strep isolated, which was treated, also had evidence of glandular fever, and a toxigenic strain of diphtheria. It's unclear as to whether that was actually the cause of the disease, but it was there and might have been. So we mustn't forget these illnesses that we think have gone away. They haven't. They are lurking in the background, and if our immunisation rates drop, then they will come back. So what can we do about this? Now, a lot of what I'm going to say applies to the whole population. It's not just a migrant population. It's equally important for a child who moves from one part of the country to another. And none of it is rocket science. So for anybody who is moving from one healthcare setting to another, whether that's one general practice to another general practice or from out of the country into the country, it is very important to ascertain their immunisation history. Now, if they're moving within the country, you may have the advantage of the Baby's Red Book, if people are using it. Mothers do, professionals not quite so much, unfortunately. Or you may have transfer of records from Child Health Records departments, and of course there will be GP transfer. If it is someone who comes from abroad, it is not enough to rely on a parent who says, my child has had all the routine things going. Disproportionately, migrants will be people who have perhaps missed out on whatever is routine. So we would say, don't assume anything and only take documented history. Anything else, discount. Look for a BCG scar, which is supposed to be a left deltoid and is supposed to be typical. And I was sitting in a meeting at the Institute of Hygiene, Tropical Medicine, some while ago, and people were asking, how would we ascertain someone's BCG status? And someone was unwise enough to say, well, you look for the typical scar, don't you? So one of the members of the research group went off to his office and brought back a pile of photographs and said, these are all typical BCG scars, and they're all different. So it's not so easy, and it's not always on the left deltoid either. Move. So once you've done that, and you are left with either a partially immunised child or an unimmunised child, the quick answer to your question is you go off to the Green Book and the HPA website. Green Book will tell you the basics. The HPA website has a very useful algorithm on catching up where somebody is unimmunised or partially immunised of whatever age. How many of you have a copy of the Green Book sitting on your practice desk? Okay. All of those, please go back, take it and ritually burn it. The Green Book in hard copy was last issued in 2006. I am almost willing to bet that every chapter has changed, and many chapters have changed 3 or 4 times. So if you are relying on that, I'm afraid it's not good enough. The way you keep up to date, unfortunately, is on the web. If you sign up for something called Vaccine Update from the Department of Health, they will actually notify you when there are changes. It's a monthly publication. So you do need that. So some general principles if someone is unimmunised or you're not certain whether they're immunised. If in doubt, start all over again. If they are partway through a primary course, there is no necessity to repeat any doses of anything. So if they had, say, their first primary 10 years ago, okay, you give them their second with the normal spacing. You don't have to start again. If a child moves in who's had MMR or measles under a year, which is not uncommon to have had measles under a year in many African countries, then that's discounted. So that's the exception to repeating doses. But that's because under a year there's a concern that maternal antibodies will mop up the vaccine and it will have no effect. But that's the one exception that I can think of. If someone comes here partway through a course, then we would transfer them onto the UK timing of the course. We may have to give them some other things as well, though. If they're going back to the USA, then they will require things to get back in. And if they're part way through a course, I would suggest they end that course. And in anticipation of a question, if it's something that's not on the routine schedule, who will pay for it? I haven't the foggiest, but I'm a mere clinician and I stick the needle in and then ask about that sort of thing. But seriously, if someone's come in, they're not at high risk, they're part way through a course of hepatitis B, it seems daft not to complete it. Now, there are some rules about upper age limits. So if you have a child who moves in at 10 years old, has had no immunisations, then you don't give them every immunisation that they should have had in the past, because they are now of an age when PCV, for example, would not be indicated. So it's not just a question of catching up, it's taking into account their age as well, which is the strength of the HPA algorithm. So these are some upper age limits, and these I would stress are for children who are not particularly at risk of any diseases. Some children who have splenic malfunction, we will go on giving PCV, much older, Hib likewise. Pertussis is 10 years purely because that's what the licence says, and of course we are giving it to people older than 10 years now, namely pregnant women. So these are guidance. Someone who worked for the HPA many, many years ago, when he was planning a family, and he was one of the exceptions, some of us don't quite plan, he and his wife had booster doses of pertussis, and this was 20 years ago, so that's foresight for you. Men C, up to 25. BCG, as a routine, only up to 16, though 35 if you're a healthcare professional. And I would emphasise you don't do this more than once in the case of BCG, whatever your MON2 test. Then there are rules in terms of intervals between vaccines, because if you've got a child who has come and is already quite old, you want to get things in as quickly as you can if you're catching up. And as a generalisation, if you're giving the same vaccine, so doses of diphtheria, tetanus, etc., you need to leave a minimum of 4 weeks. If you leave longer, you probably will get a better immunological response, but of course the person is more at risk of getting whatever disease you're talking about. But also, bearing in mind that this is likely to be a mobile population, they may well have moved on if you space it out too widely. Pneumococcal conjugate vaccine is an exception to this, where the interval should be 2 months. And if you have a child who is under 18 months, so between a year and 18 months, that for some reason you want to give 2 doses of MMR, which is perfectly reasonable if they're going to be in a high-risk situation, either because there's a lot of measles locally or they're going to a high-risk country, then you should ideally leave 3 months gap. If not, you will need to repeat it. If you are giving different inactivated vaccines, so hepatitis B and diphtheria, tetanus and polio, there is no magic interval. Anything you like. So it could be the same day, next day, 10 minutes later, 20 years later. It doesn't matter. And people sometimes get confused about this, but if it's a different vaccine, it doesn't matter. If you are giving different live vaccines, you should either give them on the same day or a minimum of 4 weeks apart. Recently, I've had a number of questions, and I carefully have phrased what I said. I didn't say at the same time, I said on the same day, because there is a scenario that sometimes crops up that a child is going to Africa, say, needing yellow fever. Does that mean the travel health clinic has got to give them the MMR as well? Could the GP give them the MMR, but there might be a couple of hours between the two being given? Doesn't matter. As long as it's the same day, that's fine. Then the other situation that crops up much less commonly now, because we don't tend to use immunoglobulin as a preventative for hepatitis A, is the interval between immunoglobulin and live vaccines. So forget immunoglobulin, dead vaccines doesn't matter. If you give a live vaccine first and then immunoglobulin, you need to leave 4 weeks. This is so that you have ample time to have an immunological response by the time you give the immunoglobulin. If you're doing it the other way around, so immunoglobulin first and then live vaccine, as a generalization you need to leave 12 weeks. Now in practice there's really only one vaccine that we use that this matters for, and that's MMR. And it doesn't matter for yellow fever. Why doesn't it matter for yellow fever? It's not endemic in this country, but suppose you're a traveller and are going abroad where it is and you need the vaccine. Why wouldn't it matter if you were given immunoglobulin, say, 2-3 weeks ago? Well, immunoglobulin comes from usually donors in this country or the States or Australia. They are not going to have a significant number of yellow fever antibodies circulating. And that's why. It's nothing magic. It's just that that's what the disease is circulating. If the immunoglobulin came from an African population or people who'd had yellow fever vaccine, that would be different. And likewise, it doesn't matter with BCG, which is a totally different immunological response. So as I say, the only one that matters in practice is MMR. BCG, as I think you will probably be told, or might be told in the next presentation, is not the best vaccine in the world, and we don't understand a lot about it. But WHO, this country, suggests you don't repeat the vaccine once you've had it, whatever your MON2 test. And as you're probably aware, there are lots of countries that don't use it at all. The reason for not repeating it is a lack of evidence that it has any beneficial effect, a theoretical risk of an exaggerated local reaction. Having said that, there are a lot of Eastern European countries that give multiple doses during childhood. And also the MON2 test, in terms of telling you whether you're protected or not, it's not very reliable after BCG. So once and once only. There will be some diseases that will be of higher prevalence amongst a migrant population, and therefore they will need extra consideration. And in the case of people with sickle cell disease, they will need extra doses of vaccine. In case of someone who's got HIV, you should not give them BCG. Certainly if they're asymptomatic, MMR would be indicated, because there are quite a few children who've died in the States with HIV and have got measles, whereas there isn't any known deaths in children being given MMR who've got HIV. And they may also need extra vaccines. This is the algorithm which you'll find on the HPA website. It was last updated September 2012, and again this will undergo updating as the schedule changes. And come this time next year, the schedule will change. Actually, come September next year it will change. Now lastly, I want to run through a scenario with you, which is not an uncommon one. This is a 5-year-old who comes from the Congo as an asylum seeker. You sit down with his parents with an interpreter, and it's not clear what vaccines he's had, and his parents, as is often the case, will not have any records except for 1 dose of oral polio vaccine and triple vaccine at 6 weeks and a dose of measles at 8 months. So what are you going to give this person who is now 5? Everything except for PCV. Well, you will bring him up to date. So he's already had one lot of some of his primaries. So you'd need to give him 2 doses of Pediacel. It's the only 5-in-1 we have currently, with a month gap. DTP, so he's had diphtheria, tetanus and whooping cough, and he's had polio. An oral polio vaccine and activated polio vaccine are interchangeable. So, sorry? What about Hib? Yes, you could as a purist argue that, but why wouldn't you give him another dose? What is different about this child from the child who comes up on time? He's 5. You only need 1 dose of the conjugate vaccines when you're over a year old. So although he has missed out, he doesn't need everything he's missed out upon because he's now older and will mount a very good response after 1 dose, let alone 2. So that's why he only gets 1 dose of Men-C, because he's over a year. I've missed out PCV. Why have I missed that out? Yep. And 2 doses of MMR and a month gap. So how would you give that little lot? Depends a little bit how sadistic you're feeling. Or another way of looking at it is how quickly you want him protected. But it would be dead simple to give him 1 each of those on first visit, 1 of those on his second visit. And you are all done then. BCG, if he hasn't had it, or you've got no good evidence he's had it, what you do would then depend upon local policy, but he probably ought to have it or at least be referred to someone for advice about it, because he will be by definition at high risk. A year later, you give him his booster. So this is where interval rather than age is important. So this is what you would call his preschool booster. And then he is back on track. So he has everything else as per usual. You don't have to leave a longer gap for his teenage booster as long as there's a minimum of 5 years gone. And importantly, everything should be recorded in both his professional records, but give him, stroke his parents, something to carry with him. Because again, he is more likely to move than the average member of the population. And anybody who tells me that health records move better than parent-held records, I will not believe. So any questions?